Welcome to the deep dive. Today, we're taking a plunge into a fundamental system within the human body, the exquisite way we manage calcium.
Hmm.
It's far more than just about bones. It's a constant, dynamic process, absolutely critical for life.
It really is. Often overlooked,
Yeah.
but so vital.
Our source material for this deep dive is a close look at key excerpts from Chapter 54, which focuses intently on what happens when the body's calcium balance goes awry, the states of too much calcium, known as hypercalcemia, and too little, called hypocalcemia.
That's the focus.
Our mission, driven entirely by this text, is to go incredibly deep into every concept, every detail presented in these sources.
Yeah, we're aiming for real depth here.
We want to unpack this material with such thoroughness that you walk away with an understanding akin to that of an elite professional in this specific physiological area, purely based on what the text lays out.
That's right. The source material makes it abundantly clear just how central calcium is. It highlights its vital roles beyond, skeletal structure. It's crucial for basic cellular function, for signaling between cells, for neuromuscular activity, which is how your nerves communicate with your muscles, for the very rhythm and contractility of your heart, for hormone secretion, and even for the complex cascade of blood coagulation that stops bleeding. It's involved everywhere.
Wow, okay.
Because calcium is involved in so many non-negotiable processes, maintaining its concentration in the extracellular fluid, the fluid outside your cells within a remarkably narrow range, is absolutely vital for survival and health.
That narrow range is key.
It is. The body dedicates significant resources to keeping this balance tight, and understanding the disorders comes down to understanding how these fine-tuned systems break down.
Absolutely. So in this deep dive, we're first going to meticulously unpack the intricate feedback mechanisms that the body uses to keep calcium levels in check, exactly as described in our source.
Laying the groundwork.
Then we'll turn our attention to what happens when those mechanisms falter, leading to hypercalcemia and hypocalcemia. We'll explore their diverse causes, how they typically present in a person, the specific diagnostic approaches outlined in the text to figure out why they're happening, and importantly, how they are treated, all strictly within the framework and details provided by the source material.
That's the goal. To distill this comprehensive information from the source, guiding you through the physiology, the pathology, the diagnosis, and the management of these critical calcium disorders, giving you a shortcut to, well, a deep understanding.
Okay, let's truly unpack this fundamental system of calcium homeostasis. How does the body manage to keep extracellular calcium concentrations within that very narrow range? The source specifies 8.9 to 10.1 milligrams per deciliter, or 2.2 to 2.5 millimolar. That doesn't leave much room for error.
It really doesn't. It's incredibly tight. And this tight regulation is achieved through a central feedback loop, described and illustrated in the text, notably referenced in Figure 54:1.
Okay.
Think of it as a finely tuned orchestra where four key players are in constant communication. The parathyroid glands, the kidney, the intestine, and bone.
The big four.
These are the organs that sense calcium levels, produce key regulatory hormones, absorb calcium from diet, and serve as the main reservoir for calcium.
Let's walk through the steps of this elegant system, following the narrative the source provides, because grasping this loop is foundational to understanding everything that follows.
Exactly. It all starts with a signal. The source describes the primary trigger as a decrease in extracellular calcium.
So when blood calcium dips,
Right. When the calcium level in the blood starts to dip, the body needs to respond immediately to bring it back up. This low calcium level acts as a signal that triggers an increase in the secretion of parathyroid hormone, or PTH.
and how does the parathyroid gland sense that the calcium is low? There must be a specific mechanism for detection.
There is. It's quite clever. The text explains the signal is received by the calcium sensor receptor, or KSR, located on the surface of the parathyroid cells.
KSR. Got it.
These receptors are essentially molecular antennae, constantly monitoring the precise concentration of calcium outside the cell. When they detect that calcium is low, they signal the parathyroid cell to ramp up production and release of PTH into the bloodstream.
So the lower the calcium, the more PTH it comes out.
Within physiological limits, yes, it's a graded response.
Yeah.
The KSR is exquisitely sensitive to these small changes.
Got it. Low calcium activates the sensor on the parathyroid, leading to more PTH. What does that PTH do once it's released? Where does it go?
PTH is the primary calcium-raising hormone, and the source outlines its key actions on its main target organs. the kidney and bone.
Okay, kidney and bone.
In the kidney, PTH increases the reabsorption of calcium in the renal tubules. Basically, as the kidneys filter your blood, PTH tells them, hold on to that calcium, don't let it escape in the urine.
Makes sense. Keep what you need.
And on bone, PTH stimulates the process of bone resorption. Now, bone isn't just a static structure, it's constantly being remodeled.
Right, broken down and rebuilt.
Exactly. PTH signals specialized cells in bone, the osteoclasts, to break down a small amount of bone tissue, releasing the calcium stored within it into the bloodstream. It's like tapping into the calcium bank.
So PTH tells the kidney to keep calcium and bone to release calcium. That seems like two direct ways to raise blood levels. But we also hear about vitamin D in this context. How does that fit into this specific feedback loop described by the source?
Vitamin D. That's the next crucial step in the response. PTH has another very important effect on the kidney. It stimulates the production of the most active form of vitamin D.
The active form?
Yes, which is 1025 dihydroxyvitamin D, often shortened to 1025 OH2D or calcitriol. The kidney possesses the necessary enzyme, 1-alpha-hydroxylase, to convert a precursor form of vitamin D, 25-hydroxyvitamin D, which reflects your body's stores, into this potent hormonally active version. PTH basically flips the switch in the kidney to make more active D.
Okay, so PTH boosts active vitamin D production in the kidney. And where does this active vitamin D primarily exert its effect in this calcium-raising loop?
The source specifies that 1025 OH2D acts principally on the intestine. Its main function there is to dramatically increase the efficiency of calcium absorption from the food you consume.
So it helps you grab more calcium from your diet?
Precisely. It essentially opens the door wider for calcium to move from your digestive tract into your bloodstream. It's a major player in getting calcium into the system from the outside.
Okay, let's put that sequence together then, based on the source. If calcium drops, the callus-R on the parathyroid senses it, causing the parathyroid gland to release more PTH.
Correct.
PTH then acts on the kidney to increase calcium reabsorption. A and D stimulate the production of active vitamin D, 1025 OH2D. PTH also acts directly on bone to increase calcium resorption, releasing stored calcium.
Right, tapping the bank.
And finally, that active vitamin D produced in the kidney goes to the intestine and increases calcium absorption from the diet.
You've got it. That's the loop. The collective effect of these orchestrated actions, increased PTH, increased renal reabsorption, increased bone resorption, and increased intestinal absorption via 1025 OH2D, is to restore serum calcium levels back up into that normal tight range.
And it's always working.
The text underscores that this is a constantly active dynamic system, always monitoring and adjusting milligram by milligram, essentially, to maintain that critical balance.
And the source makes a really critical point about the clinical relevance of all this. It states that derangements in this feedback loop often serve as a harbinger, a warning sign of underlying disease.
That's a fundamental takeaway. Because calcium regulation involves multiple organs, parathyroids, kidneys, bone, intestine, and hormonal signals like PTH and vitamin D that are themselves influenced by other bodily processes.
Right.
An abnormal calcium level isn't just an isolated finding. It's often a strong indicator that something else is going on, potentially a significant underlying condition affecting one or more parts of this intricate system. Recognizing changes in calcium is often the first clue.
A signal flare,
That's
basically.
A signal that something needs investigation.
Let's transition now and dive deep into the high side hypercalcemia. Too much calcium. The source material, notably referencing Table 54-1, provides a structured and insightful way to think about the causes of high calcium. By classifying them based on which part of that normal feedback system we just discussed is malfunctioning or being overridden.
This is a really crucial approach for getting a handle on the different etiologies. It helps us move beyond just a list of diseases and think about the fundamental physiological breakdown. Is it too much signal? Is the sensor faulty? Is there an external factor flooding the system? Where's the break?
Let's walk through the major etiologies listed and described in the text, really digging into the specific details provided for each, starting with excessive PTH production.
Okay, this is one of the main categories. The source explains that hypercalcemia results when the parathyroid glands produce and secrete PTH inappropriately.
Inappropriately meaning?
Meaning they don't adequately suppress PTH release even when serum calcium concentrations are already elevated. The off switch isn't working properly.
Gotcha.
The most common scenario causing hypercalcemia via this mechanism, according to the text, is primary hyperparathyroidism.
Primary HPT.
Right. This condition arises from primary neoplastic disorders of the parathyroid glands themselves, typically a benign tumor called an adenoma in one gland, but sometimes hypoplasia, which is enlargement of all the glands, or, much more rarely, a parathyroid carcinoma, a cancer.
And why is the PTH high in these cases, even with high calcium?
The source points to two main reasons. One, there's simply an increased mass of parathyroid cells churning out more hormone, more factories making the product.
Okay.
And two, critically, these abnormal cells often have impaired feedback inhibition by calcium. The KSR on these tumor or hyperplastic cells might not be functioning normally, or the sheer number of cells might just overwhelm the suppressive signal from the high calcium. They just keep making PTH when they shouldn't. The negative feedback is broken.
So the normal break doesn't work. What about tertiary hyperparathyroidism? The source mentions that too.
Yes, tertiary hyperparathyroidism is mentioned specifically in the context of chronic renal insufficiency, so long-term kidney failure. What happens is, over years of the kidneys failing, you often get low calcium and impaired vitamin D activation, which constantly stimulates the parathyroid glands.
Okay, long-term stimulation.
Exactly. Over that extended period, the glands can become massively enlarged, what we call hyperplastic, and sometimes develop a degree of autonomy. They just keep pumping out high levels of PTH, even if the initial stimulus, like the low calcium, is later corrected, perhaps by a kidney transplant. They've sort of gone rogue.
And ectopic PTH secretion, is that a common cause of PTH-driven hypercalcemia?
The text explicitly notes that this is very rare. It would mean a tumor somewhere outside the parathyroid glands is somehow producing actual PTH. But again, the source emphasizes this is an uncommon etiology.
Okay, very rare. Now, here's particularly insightful cause mention that ties directly back to our discussion of the calcium sensor receptor. Familial hypercalcemia, or FHH. The source describes this in some detail.
FHH is fascinating, yes. It's described as an autosomal dominant syndrome, meaning it runs in families. Source identifies the most common cause as inactivating mutations in the calcium sensor receptor gene, the CASR gene.
Inactivating the sensor.
Right, making it less sensitive. The source also mentions that in rarer families, mutations in other genes involved in the signaling pathway, GNA11 or AP2S1, can cause similar effects.
And how exactly do these mutations cause high calcium, according to the text?
The text is quite specific here. It explains that these mutations impair extracellular calcium sensing. The sensor is under-reading the calcium level, and this happens in two key places. Yes. First, in the parathyroid glands. Because the parathyroid KSR is less sensitive, it thinks calcium is lower than it actually is, leading to what the text calls inappropriate PTH secretion. The PTH level might be mildly elevated, or sometimes it's just within the normal range, but that's inappropriately normal. Given that the calcium level is high, it should be suppressed.
Okay, so the parathyroid thinks calcium is low or normal. What's the second place?
The kidneys. The kidneys also have KSRs that help regulate how much calcium is excreted in the urine. In FHH, because the kidneys' KSRs are also less sensitive to the high calcium, they fail to properly increase calcium excretion. Instead, there is increased renal tubular calcium reabsorption.
Ah, so the kidney's holding on to calcium too when it shouldn't be.
Exactly. It's a double whammy. You have inappropriately non-suppressed PTH and increased calcium retention by the kidney, both driven by the faulty sensor perceiving calcium as lower than it is. This combination leads to hypercalcemia, but characteristically relatively low calcium excretion in the urine. That's the hypocalciuric part of the name.
That makes sense. Faulty sensor in both spots. And the text's note about PTH being only mildly elevated or inappropriately normal is a key differentiator, right? It's often not sky high like in severe primary hyperparathyroidism.
Precisely. The parathyroid is responding just inappropriately for the actual calcium level. The kidney's doing the same. The source also mentions, as an aside, that other things altering KSR function, like lithium therapy, can sometimes mimic aspects of this.
Okay, fascinating condition. Moving beyond primary issues with the parathyroid gland itself, the next major category in the source is hypercalcemia of malignancy, cancer-related high calcium.
Yes, this is a very important cause of hypercalcemia, especially, as the name suggests, in individuals diagnosed with cancer. The source describes several mechanisms involved here.
What's the most common one?
The most common mechanism in many solid tumors, according to the text, is the overproduction by the tumor of PTH-related peptide, or PTHrP.
PTHrP, PTH-related peptide. Why does that cause high calcium?
Well, the source goes into detail about why PTHrP acts like PTH. It turns out that PTHrP shares a structural similarity with PTH, specifically in the crucial first 13 amino acids.
The business end of the molecule, so to speak.
Exactly. That's the part that binds to the PTH receptor. Because of this shared structure, PTHRP can bind to the same receptor as PTH on bone and kidney cells, effectively mimicking PTH's actions.
So it tricks the body.
It does. It stimulates bone resorption, releasing calcium, and it increases calcium reabsorption in the kidney, just like real PTH does.
But here's the critical distinction, right?
Yeah.
What happens to the body's own PTH in this situation?
Yes, this is an absolutely critical diagnostic point highlighted by the text. In PTHRP-mediated hypercalcemia, the body's own normal parathyroid glands sense the high calcium level caused by the PTHRP and respond appropriately by suppressing their own PTH production.
Ah, so a feedback loop is working for the real PTH.
Correct. The body's normal PTH is low, turned off by the high calcium. But the tumor is pumping out this mimic, this PTHRP, which keeps driving the calcium up anyway. This suppressed actual PTH level is a key clue that differentiates this from primary hyperparathyroidism, where PTH is high or inappropriately normal.
So high calcium with low PTH strongly points towards malignancy-producing PTHRP.
Or potentially other non-PTH-mediated causes.
Whereas high calcium with high or inappropriately normal PTH points towards primary hyperparathyroidism or maybe FHH. Got it. The text also mentions another mechanism in malignancy, lytic skeletal metastases.
Yes, some cancers, and the source specifically gives breast cancer and multiple myeloma as examples, can spread directly to the bones. When they do, they can form lytic lesions, essentially holes in the bone tissue.
They actually destroy the bone.
They do. And this physical destruction of bone matrix directly releases large amounts of stored calcium into the bloodstream, contributing significantly to hypercalcemia. It's a direct release mechanism.
Okay. The next major category listed in the source is excessive 1025 OH2D production. Too much active vitamin D.
Right. This involves dysregulation of that active form of vitamin D we talked about earlier, calcitriol. The source points to granulomatous diseases as key causes here.
Granulomatous diseases like?
Like sarcoidosis, tuberculosis, and silicosis. It also includes certain lymphomas in this category.
And how do these diseases cause high calcium?
The text explains the mechanism. In these conditions, the inflammatory cells that make up the granulomas, or the lymphoma cells themselves, can gain the ability to perform that final activation step for vitamin D. They have the 1-alpha hydroxylase enzyme.
So they make active vitamin D outside the kidney.
Exactly. They convert the circulating precursor, 25-OHD, into the potent active form, 1025-OH2D, at an uncontrolled accelerated rate, independent of PTH regulation.
And the result of all that extra active D?
The consequence, as the source explains, is primarily enhanced intestinal calcium absorption. Just like we saw in the normal loop, high levels of 1025-OH2D crank up calcium absorption from the gut. This overload of absorbed calcium leads to hypercalcemia. And similar to PTHRP-mediated hypercalcemia, the source notes that in these vitamin D-mediated cases, the body's own serum PTH levels are appropriately suppressed because the high calcium is correctly sensed by the parathyroid glands.
Makes sense. High calcium turns off PTH. The source also lists vitamin D intoxication here, right?
Yes, that's a more straightforward cause in this category. Simply taking an excessive amount of vitamin D supplements can overwhelm the system and lead to hypercalcemia via this same pathway of increased calcium absorption.
Okay, beyond hormonal issues or cancer, are there other conditions mentioned that directly impact bone to raise calcium levels?
Yes, the source includes a category for primary increase in bone resorption from other causes. Examples given are hyperthyroidism.
Overactive thyroid.
Yes, excess thyroid hormone can directly accelerate bone turnover, leading to increased breakdown and calcium release, and also immobilization.
Just not moving.
Exactly. Prolonged periods of not bearing weight on bones, like being bedridden, can lead to disuse osteoporosis, increased bone breakdown, and subsequent calcium release into the circulation. The use it or lose it principle applies to bone density.
And excessive calcium intake itself can be a cause.
It can. The text lists the milk alkali syndrome. Historically, this was linked to people consuming large amounts of milk and absorbable alkali antacids like calcium carbonate, often for ulcers.
Right.
The combination of very high calcium intake and alkali can overwhelm the kidney's ability to excrete calcium, especially if kidney function is already borderline, leading to hypercalcemia. The source also mentions total parenteral nutrition, TPN, with excessive calcium supplementation, basically, getting too much calcium directly via an IV feed.
Straight into the bloodstream. Finally, there's an other causes category mentioned. What does the source include there?
This is sort of a catch-all for various less common causes. It lists certain endocrine disorders, like adrenal insufficiency, pheochromocytoma, a tumor of the adrenal gland, and vivapoma, a rare pancreatic tumor, which can indirectly affect calcium metabolism through complex mechanisms.
Okay.
It also includes specific medications. Thiazide diuretics are a notable one. Paradoxically, they decrease calcium excretion by the kidney, which can unmask or worsen hypercalcemia. Excessive intake of vitamin A is mentioned, as are certain antiestrogens used in cancer therapy.
Wow. That is an extensive and really detailed list of why hypercalcemia can occur, all tied back to disruptions in that core regulatory system. So once someone has hypercalcemia, how does it actually show up? What are the clinical signs and symptoms? What would you or your doctor notice?
Well, the source makes it very clear that the clinical manifestations are highly variable. It's not always obvious. They depend significantly on two main factors: how high the calcium level actually gets, and importantly, how quickly it has risen.
The rate of change matters.
It does. The body can sometimes adapt, to a degree, to gradual increases, better than it can handle sudden acute spikes in calcium.
Let's go through the presentations described in the text, starting with milder cases of hypercalcemia.
Okay. Mild hypercalcemia, which the source defines roughly as levels up to approximately 11 to 11.5 milligdl, is often asymptomatic. It's frequently discovered, incidentally, on routine blood work done for some other reason entirely.
Just shows up on a panel.
Exactly. However, even in this range, some individuals may experience rather vague neuropsychiatric symptoms. The text specifically lists things like trouble concentrating, personality changes, or even depression. Subtle things.
Easy to miss or attribute to something else.
Very easy. Other potential symptoms mentioned in this mild range include gastrointestinal issues like peptic ulcer disease, or renal issues like nephrolithiasis, kidney stones, which are often made of calcium compounds. The source also notes that long-standing hypercalcemia, particularly from conditions like primary hyperparathyroidism, can increase the underlying risk of fractures, even if the hypercalcemia itself is mild.
Okay, so mild can be subtle. What about when the hypercalcemia becomes more severe? Say, the text mentions above 12 or 13 milligdl, especially if it develops rapidly.
That's when more pronounced and potentially life-threatening symptoms tend to emerge. The neuropsychiatric effects can worsen significantly, progressing from vague issues to overt lethargy, stupor, or even coma in very severe cases.
Serious neurological impact.
Definitely. Gastrointestinal symptoms also become more severe and common. The source lists nausea, anorexia, which is loss of appetite, constipation, which can be quite severe, and in some instances it can even trigger acute pancreatitis, inflammation of the pancreas.
But the kidneys?
The kidneys are significantly impacted by higher calcium levels. It leads to what the text describes as decreased renal concentrating ability. The kidneys lose their ability to conserve water effectively.
So you pee a lot.
Yes. This manifests as polyuria, excessive urination, and consequently polydipsia, excessive thirst, as the body tries to compensate for the water loss. It's a cycle that leads to dehydration, which further worsens the hypercalcemia. Severe hypercalcemia can also directly impair kidney function, raising creatinine levels.
What about bones and heart?
In cases of long-standing hypercalcemia, especially due to conditions causing chronic bone resorption like hyperparathyroidism or malignancy, the source mentions skeletal complications like bone pain or pathologic fractures occurring with little or no trauma.
Ouch.
And finally, the source highlights significant cardiac effects. Hypercalcemia can cause specific recognizable changes on an electrocardiogram, ECG. These include bradycardia, a slow heart rate, potential for atrioventricular AV block, a disruption in the heart's electrical conduction system, and a characteristic shortening of the QT interval.
Short QT interval, that's specific.
It is. And the text points out that changes in serum calcium can sometimes actually be monitored by following serial changes in the QT interval on ECGs.
That's quite a range of effects, from brain fog to coma, kidney stones to kidney failure, constipation to cardiac arrest.
Exactly. This wide spectrum of symptoms underscores why recognizing hypercalcemia can sometimes be challenging. It can easily mimic or coexist with many other medical conditions.
So given this variety in presentation, how does a clinician definitively diagnose hypercalcemia and, crucially, figure out the underlying cause? What's the systematic diagnostic approach outlined in the source material?
The text provides a clear, stepwise approach once hypercalcemia is suspected or discovered.
Okay, walk us through step one. What's the absolute first thing?
Step one is absolutely fundamental. You must ensure that the measured calcium level is truly elevated and not just an artifact of an abnormal albumin level.
Right, the binding protein issue.
Precisely. The source explains the physiology behind this. Roughly half of the total calcium circulating in your blood is bound to proteins, primarily albumin. If a patient has low albumin, maybe due to liver disease or malnutrition, their total calcium measurement might appear falsely low or normal. Even if they're ionized calcium, the unbound, biologically active form that the cells actually sense is elevated. Conversely, high albumin, maybe from dehydration, can make total calcium look high when the ionized fraction is normal.
So the total number can be misleading.
It can be. Now, the source notes that ionized calcium can be measured directly in the lab. However, it points out that these measurements are quite sensitive to how the blood sample is collected and handled, making them prone to pre-analytical errors or artifacts.
Tricky to get right.
Can be. Therefore, the text suggests it is generally preferable to measure both total calcium and serum albumin and then calculate a corrected total serum calcium level based on that albumin concentration.
Okay, how do you do that correction?
The text provides a specific formula, a common rule of thumb used clinically. For every 1.0 GDL decrement in serum albumin below a standard reference value, typically around 4.1 GDL, you add 0.8 milligdl, or 0.2 millimembers, to the measured total calcium value.
Add calcium if albumin is low.
Correct. And conversely, if albumin's elevated above that reference point, you'd subtract a similar amount. This corrected calcium level gives a much better estimate of the true biologically relevant calcium status.
That clarifies why simply looking at the number on a lab report isn't enough. You need context, specifically the albumin level. Okay, once you've confirmed the calcium is genuinely high using that correction, what's the next crucial step in the diagnostic workup according to the source?
Step 2 involves measuring the parathyroid hormone, PTH level. The source specifies using a high-quality two-site assay for the intact hormone.
A specific type of test.
Yes, these sandwich assays are designed to measure only the full-length biologically active PTH molecule, avoiding fragments that might interfere. This PTH level is the key to differentiating the major categories of causes.
And what other initial labs does the source recommend alongside PTH?
The source notes that if primary hyperparathyroidism is the cause, the increased PTH is typically accompanied by hypophosphatemia, or low phosphorus levels, because PTH tells the kidneys to excrete phosphate. So measuring serum phosphorus is important.
Okay, PTH and phosphorus. Anything else?
Yes, the text advises measuring serum creatinine to assess kidney function. This is crucial for a couple of reasons. First, as we've discussed, hypercalcemia itself can impair renal function, and second, the kidneys are involved to some extent in clearing PPH, so severe kidney dysfunction could potentially influence the measured PTH level, although the intact assays are less affected. It gives you the overall renal picture.
Okay, so you have confirmed high corrected calcium, the intact PTH level, phosphorus, and creatinine. How do you interpret that PTH level to pinpoint the cause?
The source provides the key interpretive guide. It's all about context. If the PTH level is increased, or even what the text calls inappropriately normal, meaning it's not suppressed despite the high calcium.
Right, it should be low if calcium is high.
Exactly. So if PTH is high, or normal when it should be low, and this is accompanied by the confirmed elevated calcium and typically low phosphorus, the diagnosis is almost always primary hyperparathyroidism. This pattern shows the parathyroid glands are the source of the problem. They're either overproducing PTH or failing to shut down normally.
Okay, high or normal PTH equal likely primary HPT. But you mentioned FHH earlier, which also has inappropriately normal or mildly elevated PTH with high calcium. How do you tell those two apart, especially since the source says treating them is different? Surgery works for HPT, but not FHH, right?
That's a critical differential diagnosis, and the source explicitly addresses it. It emphasizes it because individuals with FHH can present with a similar biochemical profile, hypercalcemia with non-suppressed PTH. FHH must be considered and excluded, particularly if there's a family history of mild, often asymptomatic hypercalcemia. You don't want to send someone for parathyroid surgery if they have FHH because it won't work.
So how do you check for FHH?
The key initial test recommended by the source to raise suspicion for FHH is determining the calcium-creatinine clearance ratio. This requires collecting urine, often over 24 hours, and measuring calcium and creatinine in both urine and blood.
Okay, a urine test.
This ratio essentially compares how much calcium the kidneys are clearing relative to creatinine. The source states that a ratio of less than 0.01 is highly suggestive of FHH, reflecting that characteristic low urinary calcium excretion despite high blood calcium.
Low ratio suggests FHH. What confirms it?
The definitive diagnosis for FHH, as per the text, requires genetic testing, specifically sequence analysis of the CASR gene, since that's the most common culprit. The source also notes the rarer GNA11 and AP2S1 gene mutations as possibilities. This genetic testing confirms the underlying defect in the calcium sensor. The source reiterates here that true exopic PTH secretion is exceedingly rare and thus much lower on the list of possibilities.
So, high and appropriately normal PTH points to primary HPT or FHH. Check urine calcium clearance. If low, consider genetic testing for FHH. What if the PTH level is suppressed, like appropriately low in the face of hypercalcemia?
Now that points in a completely different direction.
Mhm.
A suppressed PTH level in a patient with confirmed hypercalcemia is the major sign that the cause is not the parathyroid glands. The body's normal feedback is working correctly. The high calcium is suppressing the body's own PTH production.
So the problem is elsewhere.
Exactly. The source states this pattern is consistent with non-parathyroid-mediated hypercalcemia, and importantly, that it is most often due to an underlying malignancy. Something else is driving the calcium up, overriding the normal controls.
Mutual cancer, then.
That's the most common cause in this scenario. The source notes that often the tumor causing this type of hypercalcemia, like one producing PTHrP or causing bone destruction, is already known or clinically obvious. However, if the cause isn't apparent, the text suggests measuring a PTHP level may be necessary to specifically confirm hypercalcemia of malignancy mediated by PTHrP. The source also points out that in granulomatous disorders or vitamin D intoxication causing hypercalcemia, PTH will also be suppressed. In these cases, measuring serum 1025 OH2D levels, which would be increased in granulomatous disease, or 25 OHD levels, high in intoxication, can help confirm the diagnosis, often alongside the clinical picture.
Okay, so the diagnostic pathway really hinges on that corrected calcium and the PTH level first, using those results to guide the next steps: urine calcium, genetic tests, PTHrP, or vitamin D metabolites. Makes sense. Once a cause is identified, or even while you're figuring it out if it's severe, how is hypercalcemia treated, according to the source material? Does mild hypercalcemia always require immediate intervention?
The text clearly distinguishes treatment approaches based on severity and the presence of symptoms. For mild asymptomatic hypercalcemia, defined again as generally up to 11 or 11.5 milligdl, the source states it usually does not require immediate therapy aimed solely at lowering the calcium level itself.
So what do you do then?
In those milder asymptomatic cases, the focus shifts to managing the underlying diagnosis. For example, if it's primary hyperparathyroidism, you'd evaluate if the patient meets criteria for parathyroid surgery based on other factors like age, bone density, or kidney stones. If it's caused by a medication, you try to stop the medication. The treatment targets the root cause.
Okay. But what about significant symptomatic hypercalcemia or just very high levels?
Right. For significant symptomatic hypercalcemia or simply severe hypercalcemia, often defined as 13-14 mg/dL, regardless of symptoms, the source indicates it usually requires therapeutic intervention independent of the underlying etiology. If the patient is acutely unwell from the high calcium or the level is dangerously high, lowering the calcium becomes an immediate priority, often done concurrently while the diagnostic workup proceeds.
What's the critical initial step for managing significant hypercalcemia in that acute setting?
The source is unequivocal. Initial therapy begins with volume expansion using intravenous fluids, saline solution.
Fluids. Why is that so important?
It's not just about hydration. It's about correcting a significant fluid deficit that almost always accompanies hypercalcemia. The text explains why this is the crucial starting point. Hypercalcemia invariably leads to dehydration. It impairs the kidney's ability to concentrate urine, causing excessive water loss, that polyuria we mentioned. This dehydration worsens the hypercalcemia by reducing kidney filtration and calcium excretion. It's a vicious cycle.
So you have to break that cycle with fluids first.
Absolutely. Rehydration increases urinary calcium excretion and improves overall kidney function. The source provides specific guidance on the volume needed, suggesting that 4 to 6 liters of intravenous saline might be required over the first 24 hours just to restore adequate fluid balance.
That's a lot of fluid.
It is. And the source adds a crucial caveat. In patients who have other conditions, like congestive heart failure or severe kidney disease, this rapid fluid administration must be done very carefully to avoid fluid overload. In those situations, loop diuretics like furosemide might be used in conjunction with the saline, but critically, the text stresses that diuretics should not be started until the patient's volume status is adequately restored. You must fix the dehydration first, then diuretics can help enhance both sodium and calcium excretion.
Got it. Fluids are foundational. What therapies are used next to directly lower calcium, especially when the cause is clearly increased bone breakdown, like in malignancy or maybe severe primary hyperparathyroidism?
In situations where increased calcium mobilization from bone is a major driving force, the source says drugs that inhibit bone resorption are critical. While salmon calcitonin is mentioned as sometimes used initially because it works quickly but transiently, dose given, 48 IU/kg IM, or SC every 6-12 hours, the text clearly identifies bisphosphonates as the mainstays of therapy for potently inhibiting bone breakdown in this setting.
Bisphosphonates. Tell us more about those based on the source. What does it say?
Bisphosphonates are described as potent inhibitors of osteoclast activity, the cells that break down bone. The source gives specific examples commonly used for hypercalcemia of malignancy in adults. Zoldardronic acid, typically given as a single 4 milligram dose intravenously over about 30 minutes, and pamidronate, given as 60-90 milligrams intravenously over 2 to 4 hours.
And how well do they work?
The text details their effectiveness. It notes the onset of action isn't immediate, usually taking 1 to 3 days to see the calcium level drop significantly, but they can normalize serum calcium levels in a high percentage of patients. The source quotes 60 to 90%. It also mentions that these infusions may need to be repeated if the hypercalcemia returns, as it often does in malignancy.
Are there other options if bisphosphonates aren't sufficient? Maybe if the hypercalcemia is refractory or if they can't be used for some reason?
Yes, the source mentions denosumab as an alternative. It's described as another potent inhibitor of bone resorption and is noted to be particularly effective in hypercalcemia that is refractory, meaning resistant, to bisphosphonate treatment.
How does denosumab work?
The source explains its mechanism. It's a monoclonal antibody that targets AIRNKL, receptor activator of nuclear factor kappa B ligand. AIRNKL is a protein essential for the formation, function, and survival of osteoclasts. By blocking AIRNKL, denosumab effectively shuts down bone resorption. The source gives its specific dosing regimen for this indication. 120 milligrams given subcutaneously under the skin on days 1, 8, 15, and 29, and then every 4 weeks thereafter.
So another powerful bone-targeting agent. Any other alternatives mentioned?
Another drug mentioned as an alternative is gallium nitrate. It's given as 200 milligrams per square meter of body surface area intravenously daily for 5 days. The source notes it's effective, but carries a potential risk of nephrotoxicity, kidney damage, so it requires careful monitoring.
Okay. Are there any other, perhaps more drastic emergency interventions mentioned in the source for severe unresponsive hypercalcemia?
The text mentions that in rare instances, dialysis may be necessary. This would typically be reserved for patients with life-threatening hypercalcemia, complicated by severe renal failure, where other measures aren't working or can't be used, as dialysis can rapidly remove large amounts of calcium from the bloodstream.
Extreme measure for extreme cases. What about using IV phosphate? Does the source mention that?
It does mention intravenous phosphate, yes. And it explains why it would lower serum calcium phosphate binds directly to calcium in the bloodstream, forming calcium phosphate complexes that are removed from circulation. However, the source provides a very strong caution against its routine use.
Why the caution?
Because of significant toxicity. These calcium phosphate complexes that form can precipitate or deposit in various soft tissues throughout the body, kidneys, lungs, blood vessels, causing widespread organ damage. So while it technically lowers serum calcium, the risk of severe harm is generally considered too high and it's rarely used.
That really emphasizes the principle of first, do no harm. Okay, one last treatment scenario for hypercalcemia. How is it treated when it's caused by that excessive vitamin D production, like in sarcoidosis or other granulomatous diseases?
For hypercalcemia mediated by excessive 1025 OH2D, the source states that glucocorticoids, essentially steroids, are the preferred treatment.
Why steroids?
The source explains their mechanism in this context. Glucocorticoids work by decreasing the production of 1025 OH2D by those activated inflammatory cells in the granulomas or lymphoma. They suppress the abnormal, unregulated activity of the 1-alpha-hydroxylase enzyme in those cells.
So they target the source of the excess active D.
Exactly. Specific examples and dosing mentioned in the text include intravenous hydrocortisone, 100-300 milligrams daily, or oral prednisone, 40-60 milligrams daily, typically given for a short course of 3 to 7 days to bring the calcium down. The text also notes that other drugs that can inhibit 1025 OH2D production, like ketoconazole, chloroquine, or hydroxychloroquine, are sometimes used occasionally as alternatives or adjuncts.
All right, we've taken a very deep dive into hypercalcemia, covering its many causes rooted in that calcium regulation system, how it presents clinically from subtle to severe, the crucial steps to diagnose it accurately, and the range of treatments available based on cause and severity, all is outlined in the source. Now let's flip the coin and look at hypocalcemia 2, little calcium. How does the source material help us understand the origins of low calcium?
Well, similar to hypercalcemia, the source material organizes the causes of hypocalcemia based on how they impact that central feedback loop we discussed. But this time, the key differentiator is the serum PTH level. Is the PTH level low or inappropriately normal, suggesting a problem with the parathyroid gland itself? That's hypoparathyroidism.
Okay.
Or is the PTH level high, indicating the parathyroids are trying their best to fix the low calcium, but something else is preventing calcium from rising? That's secondary hyperparathyroidism. The source reference is Table 54-2 for this fundamental classification.
And what are the most common general issues leading to hypocalcemia noted in the text?
The source highlights impaired PTH production and impaired vitamin D production as the most common broad etiologies overall. It then makes a really crucial point about severity.
Which is?
Disorders causing deficient PTH production or secretion hypoparathyroidism may be associated with profound, sometimes even life-threatening, hypocalcemia.
Why is it potentially more severe with low PTH?
Because, as we established earlier, PTH is the body's main, most rapid defense against falling calcium levels. If that primary defense mechanism is absent or ineffective, serum calcium can drop much more precipitously and dangerously low.
Makes sense. The first responder is missing. Let's walk through the major specific etiologies listed and described in the source, starting with those associated with low parathyroid hormone levels, the hypoparathyroidism category.
Okay, under causes of low or absent PTH, the source lists parathyroidogenesis first. This means the parathyroid gland simply didn't develop properly during fetal development. This can occur in isolation or as part of broader developmental syndromes like DiGeorge's syndrome.
So born without them or with underdeveloped ones.
Correct. More commonly in adults, though, hypoparathyroidism results from parathyroid destruction.
Destruction how?
The most frequent cause cited is inadvertent damage to, or removal of, all 4 parathyroid glands during complex neck surgeries, particularly thyroidectomy, thyroid removal, or, ironically, surgery for hyperparathyroidism if it's difficult.
Surgical complication.
It's the leading cause in adults. Other causes of destruction mentioned include radiation therapy to the neck, infiltration of the glands by metastatic cancer, or systemic diseases like sarcoidosis or Wilson's disease, and autoimmune destruction.
Autoimmune.
Yes, where the body's own immune system mistakenly attacks and destroys the parathyroid cells. The source notes this is a cardinal feature of certain autoimmune polyglandular syndromes where multiple endocrine glands are affected.
Okay, agenesis or destruction. What about conditions that just reduce parathyroid function without destroying the glands?
The source mentions a few key causes here. A very significant factor is hypomagnesemia, critically low magnesium levels.
Low magnesium again. How does that affect PTH?
The text explains that severe magnesium depletion impairs both the secretion of PTH from the parathyroid glands and makes the target tissues, bone and kidney, less responsive to PTH. It's a double hit. The source notes that severe tissue injury conditions like extensive burns, rhabdomyolysis, massive muscle breakdown, tumor lysis syndrome, or severe acute pancreatitis can cause hypocalcemia, partly because the associated hypomagnesemia disrupts PTH function.
So low magnesium can effectively cause functional hypoparathyroidism.
It can. Correcting the magnesium is often essential to allow PTH to work properly again. Another fascinating cause listed under reduced function is activating mutations in the KSR, or in the G proteins that mediate KSR signaling downstream.
Activating mutations. Didn't we talk about inactivating mutations causing FHH and high calcium?
Exactly. This is the flip side. The source describes this condition as autosomal dominant hypocalcemia. Here, the mutation makes the calcium sensor hyperactive or perpetually stuck on, even when calcium is low.
So it tells the parathyroid calcium is high, even when it's low.
Precisely. It fools the gland into thinking calcium levels are adequate or high, leading it to inappropriately suppress PTH secretion. These activating mutations, the source explicitly states, lead to effects that are the opposite of those seen in FHH, which has inactivating mutations. You get hypocalcemia with inappropriately low PTH.
That really emphasizes the critical role and the delicate balance of that calcium sensor. Activating it causes low calcium, inactivating it causes high calcium.
Okay, now what about the causes associated with high parathyroid hormone levels, the secondary hyperparathyroidism category?
Right. In this situation, the PTH level is high, which tells you the parathyroid glands are sensing the low calcium and are trying to correct it by pumping out more PTH. The problem lies elsewhere. Something downstream or external is preventing that PTH from effectively raising calcium levels back to normal.
So the parathyroids are working, but hitting a roadblock. What are the main roadblocks?
The primary issues here, according to the source, relate to the vitamin D axis.
Problems with vitamin D. Yes. The source lists vitamin D deficiency or impaired 1025 OH2D production or action. This broad category includes several scenarios.
Like what?
Simple nutritional vitamin D deficiency, not getting enough from diet or sunlight, or having problems absorbing it due to gut diseases like celiac or Crohn's disease. This is very common.
Okay, deficiency.
A major cause, particularly emphasized in hospitalized or chronically ill patients, is renal insufficiency leading to impaired 1025 OH2D production. The text explains why this happens again. The kidney is the main place where the inactive precursor 25-OHD gets converted into the potent actor form 1025-OH2D under the influence of PTH. Failing kidneys can't perform this crucial activation step efficiently.
So even if you have PTH and precursor D, you can't make the active form if the kidneys are shot.
Exactly. The source also mentions vitamin D resistance syndromes, including rare genetic defects in the vitamin D receptor itself. In all these vitamin D-related issues, the low level of active vitamin D leads to poor intestinal calcium absorption and also impairs the bone's response to PTH. The resulting low calcium then appropriately stimulates the healthy parathyroid glands to secrete more PTH, hence the secondary hyperparathyroidism.
Okay, vitamin D problems are a big one. What else causes secondary hyperparathyroidism with hypocalcemia?
Other causes listed include parathyroid hormone resistance syndromes. These are typically rare genetic conditions where PTH is produced normally and vitamin D metabolism might be fine, but the target tissues, the kidney and bone, just don't respond properly to the PTH signal.
The message isn't getting through.
Right. This could be due to mutations in the PTH receptor itself or defects in the downstream signaling proteins inside the cell, like the G protein mutations seen in a condition called pseudohypoparathyroidism, PHP. The body makes PPH, but it doesn't work effectively.
Pseudohypoparathyroidism, like false hypoparathyroidism, because PTH is actually high.
Exactly. The source also lists certain drugs as potential causes of hypocalcemia, often accompanied by elevated PTH that the body tries to compensate. Examples include calcium chelators, like citrate in blood transfusions or phosphate, drugs that strongly inhibit bone resorption, like bisphosphonates, or an older drug, plicamycin, preventing calcium release from bone, and certain drugs that interfere with vitamin D metabolism, such as the anticonvulsant phenytoin or the antifungal ketoconazole.
Okay, and what about the miscellaneous causes of hypocalcemia listed?
This category includes several conditions where hypocalcemia can occur through often complex or multifactorial mechanisms. Acute pancreatitis is mentioned again here.
Pancreatitis causes low calcium too.
It can. The proposed mechanisms involve calcium soaps forming in areas of fat necrosis around the inflamed pancreas, binding up calcium, as well as potential contributions from associated hypomagnesemia or transient PTH issues. Acute rhabdomyolysis, massive muscle breakdown, is also listed, likely involving phosphate release from damaged muscle-binding calcium and kidney injury. Severe tissue injury like burns and tumor lysis syndrome fall here too.
Complex situations.
Yes. Two more specific miscellaneous causes are mentioned. One is hungry bone syndrome.
Hungry bone. Sounds intriguing.
It occurs typically after successful surgery to remove overactive parathyroid glands, like removing a large adenoma causing primary hyperparathyroidism. Before surgery, the high PTH was constantly pulling calcium out of the bones. After the PTH level plummets post-surgery, the chronically starved bones suddenly start rapidly taking up large amounts of calcium from the bloodstream to remineralize.
So the bones get hungry for calcium.
Precisely, leading to sometimes severe, prolonged hypocalcemia until the skeleton replenishes its stores.
Wow. And the last miscellaneous cause.
The final one listed is osteoblastic metastases, associated with marked stimulation of bone formation. This is the opposite of the thallitic metastases we discussed with hypercalcemia. Certain cancers, and the source gives prostate cancer as a prime example, can cause metastases that stimulate osteoblasts, the bone-building cells.
So they build bone instead of destroying it.
Yes, but this rapid, excessive new bone formation uses up large amounts of calcium and phosphate from the bloodstream, potentially leading to hypocalcemia and hypophosphatemia.
It's noteworthy that the source makes the point we touched on earlier. The degree of hypocalcemia seen in vitamin D disorders is generally less severe than that caused directly by hypoparathyroidism.
Yes, that distinction is clinically important and reinforces the idea that having some PTH response, even if vitamin D is low or not working well, provides a partial buffer against extreme drops in calcium compared to when the primary PTH defense is completely absent.
Okay, we've covered the diverse causes. What about the clinical signs and symptoms of low calcium? How does hypocalcemia manifest in a person? How would you know?
Well, again, similar to hypercalcemia, the presentation really varies with the severity and, importantly, the rate of the drop in calcium levels.
Yeah.
The source notes that mild and chronic decreases in serum calcium may actually be asymptomatic, discovered incidentally.
But when the levels drop more significantly or quickly?
That's when the classic symptoms emerge. Moderate to severe hypocalcemia is classically associated with paresthesias.
Paresthesias, that tingling and numbness feeling.
Exactly. The source specifies these are typically felt first in the fingers, the toes, and characteristically around the mouth in the circumoral region.
Why does low calcium cause that?
The text explains this is a direct result of increased neuromuscular irritability. Low extracellular calcium concentrations make nerve and muscle cell membranes more excitable, closer to their firing threshold. They become hyperexcitable, leading to spontaneous nerve firing perceived as tingling or numbness.
Okay, increased neuromuscular excitability. Are there physical exam signs clinicians look for that reflect this?
Yes, the source describes two classic physical signs that are tests for this latent hyperexcitability, often called tetany. The first is Chvostek's sign.
Chvostek's. How do you test for that?
It involves lightly tapping over the facial nerve, just in front of the ear. A positive sign is a twitching of the facial muscles on that side, particularly the muscles around the mouth and nose. However, the text includes an important caveat.
Which is?
Chvostek's sign can actually be present in about 10% of individuals who have perfectly normal calcium levels.
Yeah.
So, while suggestive, it's not absolutely specific for hypocalcemia.
Okay, not definitive. What's the other sign?
The other sign, Trousseau's sign, is generally considered more specific for hypocalcemia.
Trousseau's. How is that elicited?
To test for Trousseau's sign, you inflate a standard blood pressure cuff on the patient's upper arm to a pressure slightly above their systolic blood pressure, and you keep it inflated for about 3 minutes.
Cut off circulation temporarily.
Essentially, yes. This induces ischemia, or reduced blood flow, to the nerves in the arm. In someone with hypocalcemia, this ischemia further enhances that underlying neuromuscular irritability. A positive Trousseau sign is the development of a characteristic carpal spasm.
Carpal spasm. What does that look like?
It's an involuntary, often quite painful, contraction of the hand and fingers. The wrist flexes, the fingers extend at the knuckles but flex at the joints further down, and the thumb adducts across the palm. It's sometimes called obstetrician's hand. Seeing this during the test is a strong indicator of significant hypocalcemia.
Wow, that sounds quite dramatic. And in cases of really severe hypocalcemia, what can happen then?
Very severe hypocalcemia can lead to much more serious and potentially life-threatening neuromuscular complications. The source lists generalized seizures, more severe and sustained cramping known as carbopedal spasm, affecting both hands and feet, bronchospasm, constriction of the airways causing wheezing, and even laryngospasm.
Laryngospasm.
Spasm of the vocal cord. This can actually obstruct the airway and become a true medical emergency, requiring immediate intervention.
That's frightening. What about cardiac effects of low calcium?
Yes, severe hypocalcemia also has cardiac effects, notably on the ECG. It causes a prolongation of the QT interval. This is the opposite effect of hypercalcemia, which causes a short QT. The text again notes that just like with high calcium, changes in serum calcium levels can often be tracked by monitoring changes in the QT interval on serial ECGs. These neuromuscular signs, particularly a positive Trousseau sign, and the more severe spasms or seizures, are often quite striking clinically. Once you recognize them, they strongly point towards a potential calcium imbalance and prompt immediate investigation.
Okay, so you suspect hypocalcemia based on symptoms or signs, or find it on a lab test. How do you then figure out the specific cause? What's the diagnostic approach outlined in the source material?
The diagnostic approach, logically enough, mirrors the structure used for hypercalcemia. It starts with confirming the calcium level is truly low, and then assesses the hormonal axis, but with a crucial added focus on related mineral levels, especially magnesium.
Okay, detail the steps for us.
First, of course, you measure serum calcium. And just like with high calcium, you also need to measure serum albumin so you can calculate the corrected calcium level, ensuring the hypocalcemia isn't just due to low albumin.
Always correct for albumin. What else?
Critically, you also need to measure serum phosphorus and, very importantly, serum magnesium levels right at the outset.
Why is magnesium so crucial here?
As we discussed under causes, the source stresses the importance of checking magnesium because hypomagnesemia is such a frequent cause or major contributor to hypocalcemia, particularly refractory hypocalcemia. Low magnesium can both impair PTH secretion and cause PTH resistance. It must be identified and treated for the calcium to correct properly in many cases.
Okay, so corrected CAB, albumin, phosphorus, and magnesium are the starting labs. Then the next crucial step is interpreting the PTH level.
Yes, exactly. Once you have those initial mineral levels, you interpret the PTH level in the context of the confirmed hypocalcemia. The interpretation branches here.
Branch number 1.
If the PTH level is suppressed or inappropriately low, given the low calcium level, this establishes that the underlying problem is absent or reduced PTH secretion. In other words, the diagnosis is hypoparathyroidism.
So low calcium with low PTH means the parathyroid gland isn't doing its job.
Correct. The source then notes that a careful patient history can often reveal the likely underlying cause of the hypoparathyroidism was their previous neck surgery. Is there a known autoimmune disorder? Is there a family history suggesting a genetic form?
Okay, that's the low PTH branch. What if the PTH level is elevated?
If the PTH level is elevated in the setting of confirmed hypocalcemia, this signifies secondary hyperparathyroidism. It tells you the parathyroid glands are responding appropriately to the low calcium signal by trying to increase PTH production. The problem isn't the parathyroid itself.
The problem is downstream or external.
Exactly. The source states that this pattern, low calcium with high PTH, should immediately direct your diagnostic investigation towards disorders of the vitamin D axis or PTH resistance.
How do you evaluate the vitamin D axis specifically, according to the text?
The source recommends measuring specific vitamin D metabolites depending on what you suspect. To assess for common nutritional vitamin D deficiency or potential malabsorption, the key test is measuring serum 25-hydroxyvitamin D, 25-OHD levels. This is the main circulating precursor form and accurately reflects the body's overall vitamin D stores.
So low 25-OHD suggests deficiency or absorption issues.
Correct. However, if you suspect an issue specifically with the activation of vitamin D by the kidney, such as in chronic renal insufficiency, or if you suspect a rare vitamin D resistance syndrome, then measuring the active form, serum 1025-dihydroxyvitamin D, 1025-OH2D, becomes more appropriate. In kidney failure, for instance, 25-OHD might be normal, but 1025-OH2D would be low.
So the PTH level is the key branching point. Low PTH likely means a primary parathyroid problem. High PTH likely points towards a vitamin D issue or PTH resistance, prompting measurement of 25-OHD or 1025. OH2D, once the cause is generally pinned down, how is hypocalcemia treated according to the source material?
As with hypercalcemia, the treatment approach is tailored. It depends heavily on the severity of the hypocalcemia, the rapidity of its onset, and critically, whether the patient is experiencing acute symptoms or complications like tetany, seizures, or laryngospasm.
Let's start with acute symptomatic hypocalcemia. What's the immediate management?
Acute symptomatic hypocalcemia is considered a medical emergency and requires prompt management with intravenous calcium. The source gives specific details for this emergency treatment.
What are the specifics?
Typically, 1 ampule, which is 10 milliliters, of a 10% weight per volume solution of calcium gluconate is used as an initial bolus. The text clarifies this provides about 90 milligrams or 2.2 millimoles of elemental calcium. It should be diluted, usually in 50 milliliters of 5% dextrose or 0.9% sodium chloride, normal saline, and administered intravenously slowly over about 5 minutes. This rapid infusion helps to quickly raise the serum calcium level and alleviate acute neuromuscular symptoms like tetany.
Okay, an IV calcium and gluconate bolus for emergencies. And if the hypocalcemia persists or requires ongoing support after the initial bolus?
If the hypocalcemia continues or is expected to be prolonged, for instance, after neck surgery or in severe pancreatitis, it often requires a constant intravenous infusion to maintain adequate calcium levels. The typical setup described in the source is adding multiple ampules, often 10 ampules, providing a total of 900 milligrams of elemental calcium to 1 liter of 5% dextrose or normal saline, and then administering this solution as a continuous infusion over 24 hours, adjusting the rate based on frequent monitoring of serum calcium levels.
And what about magnesium?
Crucially, the source reiterates here that any accompanying hypomagnesemia must be identified and treated concurrently with appropriate intravenous or oral magnesium supplementation. Correcting the low magnesium is often absolutely necessary to successfully treat the the hypocalcemia, especially if impaired PTH secretion or action due to low magnesium is part of the problem.
Can't forget the magnesium. What about the long-term management of chronic hypocalcemia, such as in a patient with permanent hypoparathyroidism after surgery?
Chronic hypocalcemia, particularly that due to permanent hypoparathyroidism, requires lifelong management with oral calcium supplements and some form of vitamin D therapy to maintain calcium levels.
What kind of doses are we talking about?
The source recommends elemental calcium supplementation, typically at doses of 1,000 to 1,500 milligrams per day, emphasizing that this should be given in divided doses throughout the day for better absorption. For the vitamin D component, there are a couple of options mentioned.
Which are?
You can use either high doses of the precursor forms, vitamin D2, ergocalciferol, or D3, cholecalciferol, often requiring 25,000 to 100,000 units daily, or even more. Or, perhaps more commonly used now for hypoparathyroidism, you can use calcitriol 1025 OH2D, the already active form. Because it's active, it's given in much smaller microgram doses, typically 0.25 to 2 micrograms per day. The source notes that other vitamin D metabolites like dihydrotestosterol or alpha-calcidiol are used less frequently these days.
Is there anything else for chronic hypoparathyroidism?
Yes, the source highlights what it calls a significant recent advance in treatment. Recombinant human PTH 184, marketed under the brand name Netpara, is now FDA approved specifically for the management of refractory hypoparathyroidism. This offers an actual PTH replacement therapy option for select patients whose calcium levels are difficult to control with conventional calcium and vitamin D therapy alone.
PTH replacement, interesting. Now, what if the underlying cause of the chronic hypocalcemia is simply vitamin D deficiency itself, not hypoparathyroidism? How is that treated?
If the primary problem is confirmed to be vitamin D deficiency, then the treatment is, logically, vitamin D supplementation. The source notes that the dose required really depends on the severity of the deficiency and whether there's an underlying issue with absorption.
How do the doses differ?
Simple nutritional deficiency might respond well to relatively lower repletion doses. For instance, the source mentions 50,000 IU of vitamin D given 2 to 3 times per week for several months, followed by a lower maintenance dose. However, if the deficiency is due to malabsorption, like in gut disease, much higher daily doses, potentially 100,000 IU per day or even more, might be necessary just to achieve adequate blood levels.
Requires careful monitoring then. What is the ultimate goal for managing chronic hypocalcemia, according to the source? It seems like you wouldn't want to push the calcium level too high, maybe.
That's a critical point, and the text emphasizes it clearly. The treatment goal for chronic hypocalcemia is generally not to achieve mid-normal or high normal calcium levels, but rather to bring serum calcium into the low normal range, or sometimes even slightly below normal, as long as the patient remains asymptomatic.
Low normal. Why aim low?
The source explicitly states the reason for this seemingly counterintuitive target. It's primarily to avoid inducing hypercalciuria, which is excessive calcium excretion in the urine.
Ah, because if you push blood calcium higher with supplements and vitamin D, especially without PTH helping the kidney reabsorb it, a lot spills into the urine.
Exactly. Particularly in hypoparathyroidism, where PTH action on the kidney is missing, pushing serum calcium into the mid or high normal range often leads to significant hypercalciuria. And chronic hypercalciuria carries a major risk of nephrolithiasis, the formation of painful calcium-containing kidney stones, and potentially even long-term kidney damage, nephrocalcinosis. So the aim is a careful balancing act. Keep calcium high enough to prevent symptoms of hypocalcemia, like tetany, but low enough to minimize the risk of kidney stones.
That demonstrates the ongoing delicate balance required, even during therapy. Fascinating. Before we wrap up this very deep dive, the source includes a brief section on global considerations regarding these calcium disorders. What interesting perspective does it offer?
Yeah, this short section adds a useful layer of real-world context. It highlights how factors that go beyond the basic physiology, particularly things like access to healthcare and routine screening practices, can significantly influence how these disorders actually present in different populations around the world.
Interesting. Tell us about the specific points mentioned.
The source makes an interesting contrast regarding primary hyperparathyroidism. It notes that in countries or regions with more limited access to routine healthcare, or where widespread biochemical screening, like measuring serum calcium, isn't common,
Right.
primary hyperparathyroidism is less likely to be caught early when it's mild or asymptomatic. Instead, it often presents later in its more severe form, characterized by significant skeletal complications. The source specifically mentions osteitis fibrosis cystica, which is a severe form of bone disease resulting from prolonged excessive PTH action, causing bone pain, cysts, and fractures.
So it presents with the late-stage bone problems.
Often, yes. This is contrasted sharply with the typical presentation in many developed countries, where, due to the prevalence of routine multi-panel blood tests that include calcium, primary hyperparathyroidism is now frequently discovered, incidentally, in a much earlier asymptomatic or minimally symptomatic stage, long before severe bone disease develops.
So screening makes a huge difference in how the same disease shows up. What else?
The source also points out a seeming paradox regarding vitamin D deficiency. It notes that deficiency can be surprisingly common in some countries that have abundant sunlight, using India as a specific example.
Wait, lots of sun, but low vitamin D how?
The text explains the reasons cited for this paradox include cultural practices or personal choices that lead to significant avoidance of direct sun exposure, like wearing concealing clothing or staying indoors, coupled with dietary habits that may involve relatively poor intake of vitamin D-rich or fortified foods. So, despite the potential for sun-induced vitamin D synthesis, lifestyle and diet can still lead to widespread deficiency.
It's a powerful reminder, isn't it? While the underlying physiology of calcium regulation is universal, how these mineral disorders actually manifest, how they're detected, and consequently how they're managed, can be significantly shaped by socioeconomic factors, cultural practices, and healthcare system access.
Absolutely. It adds another important layer of complexity to the clinical picture when thinking about these conditions globally.
Wow, that was an incredibly deep dive indeed into the intricate world of calcium balance and its disorders, guided entirely by the source material from Chapter 54. We've meticulously explored that fundamental feedback loop involving the parathyroid glands, kidney, intestine, and bone, really understanding how that exquisite balance is normally maintained.
We've dissected the many diverse causes of both hypercalcemia, ranging from primary parathyroid issues like adenomas and FHH, through malignancy with PTHRP or lytic Mets, to vitamin D disorders from granulomas or intoxication, and even medications or immobilization and hypocalcemia,
Right.
including the causes of low PTH like post-surgical damage or autoimmune disease, the critical role of hypomagnesemia, activating KISR mutations, and then the high PTH states driven by vitamin D deficiency, kidney failure, PTH-resistant syndromes, hungry bone, and more.
We've looked closely at how these imbalances translate into clinical signs and symptoms, from those vague neuropsychiatric changes or GI issues in mild hypercalcemia, to the dramatic neuromuscular findings like paresthesias, Schwastack's, and Trousseau's signs in hypocalcemia, and the critical cardiac effects like the opposing QT interval changes.
And we've walked through the systematic diagnostic approach presented in the source, emphasizing the absolute necessity of correcting calcium for albumin first, then using the intact PTH level as a key differentiator to guide further investigation, whether that involves checking urine calcium for FHH, ordering genetic tests, measuring PTHRP for malignancy, or assessing 25-OHD or 1025-OH2D levels for vitamin D issues.
And finally, we've delved into the specific treatment strategies outlined in the source, from that crucial initial step of aggressive volume expansion for severe hypercalcemia and the subsequent use of potent bone resorption inhibitors like bisphosphonates and denosumab, or glucocorticoids for vitamin D excess, to the emergency management of symptomatic hypocalcemia with IV calcium gluconate, the essential co-treatment of hypomagnesemia, and the chronic management strategies using oral calcium, various forms of vitamin D, and even the exciting development of PTH replacement therapy for refractory hypoparathyroidism, always keeping that careful low normal calcium target in mind for chronic cases to avoid kidney stones.
Truly getting a deep professional level handle on this topic, as the source material allows, really involves understanding how those specific breakdowns occur within that core PTH vitamin D kidney bone intestine axis, and how they lead logically to the different disorders we've discussed. Seeing how conditions ranging from parathyroid tumors to widespread cancer, inflammatory diseases like sarcoidosis, chronic kidney failure, rare genetic mutations affecting the calcium sensor, and even diet and lifestyle factors all converge on this single vital mineral system really highlights its absolute central role in overall health.
It really underscores the interconnectedness of our bodily systems, doesn't it? And the detective work involved in medicine when symptoms might be vague, like mild confusion or fatigue, but could potentially point towards a fundamental imbalance like hypercalcemia. Recognizing the more specific clues, like those paresthesias or the Trousseau's sign for low calcium or the ECG changes, provides essential diagnostic leads.
Absolutely. And the diagnostic framework presented the source, starting with corrected calcium, then PTH, then targeted follow-up tests based on that result, provides such a logical and systematic roadmap for clinicians to uncover the root cause. The range of treatments, chosen specifically based on that identified cause and the severity of the imbalance, demonstrates the precision required in effectively managing these potentially dangerous conditions.
So, having taken this comprehensive deep dive and explored really every concept presented within our source material on this topic, what does this all mean for you, the listener? Well, beyond hopefully gaining this detailed, perhaps even elite level understanding of calcium homeostasis and its common disorders, perhaps it offers a new appreciation for the invisible, constant physiological work your body is doing right now, second by second, just to maintain incredibly tight parameters like serum calcium. It highlights how seemingly simple numbers on a lab report can actually be profound indicators of complex underlying physiological or pathological processes.
And consider this as a final provocative thought, building directly on a point the source material made early on. The text emphasizes that even mild, apparently insignificant alterations in serum calcium, perhaps found incidentally on a routine checkup, can serve as a harbinger of underlying disease.
That warning sign idea again.
Exactly. Now, given the vast and incredibly varied list of potential causes we've just meticulously reviewed from the source causes, ranging from common post-surgical complications and nutritional deficiencies to autoimmune diseases, various forms of cancer, granulomatous infections, kidney failure, rare genetic syndromes affecting the calcium sensor or PTH receptor, and even medication side effects, does knowing the sheer breadth of these possibilities make you reflect differently on the potential importance of taking even seemingly minor lab abnormalities seriously, and perhaps consider the depth of investigation that might sometimes be necessary to truly understand the body's subtle signals and ensure underlying conditions aren't missed.
A lot to contemplate there. The body sends signals, and sometimes we need to listen very closely. Thank you for joining us for this comprehensive deep dive into hypercalcemia and hypocalcemia, based entirely on the detailed source material provided. We hope it's given you a robust, perhaps even elite level understanding of these critical conditions.